My name is Julia Schofield, and this is my presentation entitled A SMART Showcase. My study aimed at lowering the rate of unsuccessful discharges from the Adult Intensive Outpatient Program. I proposed to incorporate a SMART Goals directive into the initial treatment planning session, which was monitored weekly individually, as well as setting and discussing weekly SMART Goals in group. The intervention I proposed to incorporate at my internship site was to tackle the rate of unsuccessful discharges from two main angles. One, it'll work in increasing the average score on the satisfaction survey given to all patients at discharge by targeting the response, quote, "I had input into my treatment goals," end quote. Second, I believe weekly SMART goals will motivate and hold clients accountable to their treatment and thus create a higher discharge success rate. My rationale behind the implementation of SMART goals in these two areas is as follows. I propose that by encouraging the client to create a SMART goal as their main treatment goal, it will make the treatment seem more accessible and allow the client to feel in greater control of their care, and thus, more control, more accessible, clearer focus equals higher successful discharge rates. Furthermore, by creating weekly SMART goals and group sessions and being held accountable to these goals by staff and peers, I think it would make clients more mindful of their treatment outside of group sessions and motivated by their progress, and thus less likely to discontinue treatment prematurely. This intervention is needed for a couple of reasons. Number one, because it allows patients to take ownership over their treatment goals. While I often helped clarify or guided clients to make goals more specific, the goal itself was primarily in the patient's hands, which was not the typical case at my internship site. The typical procedure before my implementation was to get a client statement, for example, "I want to be less depressed," and then the designated therapist would create a treatment plan in which the client was typically not involved. When surveyed, on average, only 1 out of 4 IOP patients from January to March of 2020 could actually state the treatment goal on their treatment plan. The second reason this intervention is needed is through weekly check-ins on treatment goal progression, staff is informed in areas where the client is still struggling, and this helps staff tailor the skills group to the patient's current needs. The weekly goals set up in groups are needed in that creating SMART goals in group keeps the patient motivated and held accountable. It has been my experience leading groups that the vast majority of my group members are not actively working towards any goals at home and sometimes even in group. For example, previous goals from IOP patients from January to March have been to play video games, which is something these patients do regularly for hours on end, or my goal for today is to think of a goal. This shows little thought, planning, or motivation to continue with treatment outside of group. By requiring each patient to create a goal that needs to be done outside of the group pushes the patient to think about their treatment in their day-to-day living. Also, having to report on their efforts to fellow groupmates provides a level of accountability and motivation not currently provided in the group program, and it is also a way to receive support and feedback from group members. The population for this study are adult men and women 18 years and older attending an IOP program at a hospital in Illinois. As previously mentioned, this population has been selected due to an inability to verbalize treatment goals, as well as a demonstration of low motivation to work on treatment goals outside of group. IOP patients are not in need of inpatient care, but do require more intense treatment than 1 or 2 individual weekly sessions. Admitted patients are typically battling a wide array of mental health issues, for example, bipolar with psychosis, anxiety, suicidality, and self-harming, depression, dual diagnosis, and schizophrenia. Patients also come from quite disparate educational backgrounds and IQ levels, some being on the autism spectrum, with most patients having completed some or all of high school. Patients are typically, but not limited to, ethnic minorities from lower socioeconomic backgrounds. Intervention for treatment goals is as follows. After completion of the psychosocial assessment, I ask patients to identify a problematic behavior they would like to work on, and this will be their treatment goal. A real IOP patient example would be, "I want to work on my anxiety." I then explain what a SMART goal is and ask them if they can make their goal specific, measurable, achievable, realistic, and time-bound. Continuing with the same client example from above, I ask the patient what their anxiety symptoms currently look like and where they would currently rate their anxiety on a scale of 1 to 10. 1 being no anxiety, to 10 being extreme anxiety. With the patient's answer, I ask the patient to choose which symptoms they find most impairing and would like to target, and I then ask where they would realistically like to rate their anxiety in the next 4 to 6 weeks. After gathering this information, the patient is then able to create their SMART treatment goal. For example, my anxiety is currently a 6 out of 10 daily and I have 5 panic attacks a week. My goal would be to rate my anxiety as a 4 out of 10 daily and have 2 or fewer panic attacks per week for 2 consecutive weeks before discharge. I write both the client original statement and then the SMART goal statement on their treatment goal. Each Monday, I did a 5-minute check-in call to the patient to see where they are at in their progress towards their goal. In the call, I asked them to verbalize their treatment goal and ask on a scale of 1 to 10, where are you at achieving your goal? 1 being no progress to 10 being goal achieved. Based off of their score, I asked them what is keeping them at their current score. For example, I feel like I am a 6.5 out of 10 because I don't feel as anxious, but my panic attacks come out of nowhere and so I can't stop them. From their report, I am able to tailor the skills group for the week to target their main struggle areas. For example, how to identify and manage triggers. For the weekly goal intervention, I created and implemented a SMART Goals worksheet, visualized to the right, in which patients have to fill out each week. Due to the COVID-19 telehealth adjustments, each patient verbally stated their goals while staff entered it into the worksheet via screen share, and a filled out copy was sent to the patient's email. Patients could choose any goal of their liking that they felt would benefit them in some way. Real examples include call the dentist, break up with boyfriend, go for a minimum 5-minute walk 3 times a week, drink 8 glasses of water each day, make my bed every morning before group. Each day, clients report on progress or stagnation on their goal to the group. For those who are not able to complete their goal, staff would ask, what do you need from the group today to help you achieve your goal? Patient replies often included support, feedback, or suggestions, challenge as to why they didn't follow through, or encouragement that they can do it. As a reminder, I proposed implementing SMART goals with the idea that it would make clients feel more in control of their care, motivated by progress, and thus less likely to prematurely discharge. I will be evaluating the outcome of the SMART goal intervention in 3 different ways. First, I will be evaluating the treatment goal intervention success through targeting feedback from the outpatient survey. Every patient is asked to fill out an outpatient satisfaction survey when they are discharging, whether successfully or not. On the satisfaction survey, statement number 8 states, quote, I had input into my treatment goals, end quote. The average score from this statement over the past 4 quarters is 4.63 out of 5. My goal is to increase this score to 4.7 from the period of March 15th to May 15th, 2020. I chose this score as it is higher than the highest score within the previous year. The second form of evaluation is to calculate the average number of unsuccessful discharges per month in the IOP program from January 2019 through to February 2020, and compare this number of unsuccessful discharges from the date of implementation, March 15th, 2020 to May 15th, 2020. Success of the intervention would see a decrease in the percentage of unsuccessful discharges. Lastly, I will evaluate the efficacy of the SMART Goals intervention through qualitative feedback from patients by asking patients in their last week of treatment, quote, how has creating SMART Goals impacted your treatment? My goal was to raise the client satisfaction score from an average of 4.63 out of 5 to 4.7. As you can see as depicted in the table, the average score from previous quarters is 4.63. The highest score, which was found from January to March 15th, 2020, was 4.69. And so I set my target to be 4.7, which would be the highest score as of yet. As you can see, as depicted under Intervention Score 2020 March 15th to May 15th, the average patient satisfaction score is 4.71. The latest results do show an increase in patient satisfaction in terms of having input into their treatment goals, and thus the results are promising, but I will discuss recommendations and limitations to these results in an upcoming section. Results for discharge rates. The average percent of monthly unsuccessful discharges from the IOP program over the past 12 months is 54%, meaning that from March 2019 to March 2020, the average rate of unsuccessful discharges per month was about 54% of the discharges were considered unsuccessful. After implementation of client-created SMART treatment goals and weekly SMART goals, the monthly unsuccessful discharge rate did decrease, with March supporting an unsuccessful discharge rate of 32%, April a unsuccessful discharge rate of 29%, and May supporting a unsuccessful discharge rate of 26%. It would thus appear that SMART goals implementation correlates with a decrease in unsuccessful discharges, which was the proposed outcome. However, there are limitations that will be discussed in a couple of slides. Finally, the results from the qualitative feedback question that was posed during a patient's last week of treatment came back as mostly positive. 15 responses were recorded. 10 out of 15 were qualified as positive, and 5 out of 15 were qualified as neutral. A positive response would be considered as such: SMART goals impacted my treatment by helping me see improvements in my day-to-day life. Or, I needed to be held accountable, and knowing that you were going to check in, it pushed me to actually do it. Or, I have more routine in my day now, and I think I'm going to start adding days of the week chores. Neutral remarks were considered as: how did SMART goals impact your treatment? Response: I did them. Or, I guess they helped keep me on track. Of the 15 responses gathered, no negative responses or complaints by patients in response to SMART goals were reported. There are some obvious limits to this study, namely all this data is correlational and in its early phases, and while it demonstrates positive results, it is too early to tell if this will be a continued trend, and thus I would recommend continuation of application to see if results remain the same over time. While the results from the target satisfaction survey were on average with previous number of survey satisfaction respondents, I would still like to see this continued application to see if this continues. Another limitation to the result is that discharge rates could be impacted by COVID-19 and that participants may be more willing to complete treatment due to the fact that they have little else to do or less job schedule interference. Again, continuation of intervention and under normal operating conditions would be necessary to rule out this confounding variables effect. Furthermore, I chose to target I had input into my treatment goals, as I believed, along with some studies listed on the slide, that greater input and control would lead to greater rates of successful discharges. However, for the sake of the IOP program, an increase in satisfaction survey results may not actually be a valid measure of a patient's increased likelihood to see their treatment all the way through. Lastly, a limitation to the qualitative feedback could be that patients are simply obeying demand characteristics of the situation and telling me what they think I want to hear. A way to control for this in the future would be to allow the patient to write out their feedback alone and submit it without their name on it. This could attempt to control for some sort of bias. While the results are promising, continuation of this intervention would be needed to see if these positive results continue forward. As of right now, it is promising, but it is too early to tell.